Welcome back to EP Edge Journal Watch. I'm Dr. Sharma and I'm grateful you're here. If you've been listening regularly, sharing episodes or sending feedback, thank you. I know your time is valuable and it means a lot that you choose to spend a few minutes with me each week. All right, let's get into today's Journal Watch. Here's what we'll cover. First, those almost AF runs, irregular atrial arrhythmias that are under 30 seconds. Do they matter or are they noise? Second, metabolic modulation, specifically semaglutide, used around the time of ablation in patients with obesity and paroxysmal atrial fibrillation. Does it meaningfully change recurrence and arrhythmia burden? Third, nanosecond pulse field ablation for paroxysmal atrial fibrillation, 12-month outcomes and a workflow that leans heavily toward conscious sedation. Fourth, a high-stakes safety signal, generalized coronary spasm in Marshallese patients after pulse field ablation, rare globally, potentially common locally, and potentially catastrophic. Fifth, implantable loop recorder accuracy. How often alerts are true, how often they are false, and how much the vendor matters. Sixth, practical intraprocedural safety cues for left bundle branch area pacing, distinct electrogram waveforms that flag septal perforation. Seventh, validation of the PADIT risk score for device infection. And an important twist, pocket infection and systemic infection behave differently. And eighth, polycystic ovarian syndrome and long-term risk of arrhythmias, including atrial arrhythmias, conduction disease, and even device implantation over decades. Okay, let's start with the shortest episodes that can create the biggest clinical uncertainty. Study 1 asks a deceptively simple question. If you see an irregular atrial arrhythmia that looks like atrial fibrillation, but it's under 30 seconds, does that predict that the patient will declare true atrial fibrillation later on the same monitoring period? The clinical context matters here. Our diagnostic threshold in ambulatory electrocardiography has been anchored to the 30-second rule. But in the real world, people have shorter atrial fibrillation-like bursts all the time. So the question is not, do we anticoagulate a 6-second episode? The question is, should that 6-second episode change what we do next? This analysis used 30-day continuous ambulatory electrocardiography data over 32,000 United States patients with full disclosure monitoring and technician verification of events. They focused on irregular supraventricular episodes without clear P waves that would have been called atrial fibrillation if they lasted longer. Here's the key signal. In the final cohort, early ultrashort episodes under 30 seconds were uncommon, under 1%, but when they happened, the risk enrichment was dramatic. Nearly half of those patients went on to have atrial fibrillation lasting at least 30 seconds during the same monitoring window. Statistically, the adjusted hazard ratio for progressing to atrial fibrillation lasting at least 30 seconds was a little over 8. That is not subtle. Now let's interpret that carefully. This does not mean we should relabel every short run as atrial fibrillation and start treatment reflexively. What it does mean is that an early atrial fibrillation-like burst under 30 seconds can be a high signal-to-noise marker that the patient is about to declare longer atrial fibrillation. So what do you do Monday morning with this? Think of this as a trigger for escalation of ascertainment. If downstream decisions depend on confirming atrial fibrillation, especially in a patient with meaningful stroke risk, this is the kind of finding that should push you toward longer monitoring, not reassurance. Limitations: they do not have granular clinical risk information like stroke risk variables. And the rarity of early ultrashort episodes means this is a small subgroup, even in a big dataset. But the directionality is hard to ignore. Ultrashort does not necessarily mean unimportant. Okay, now let's move from signal detection to substrate modification. Study 2 lies at the intersection of electrophysiology and metabolism. We all know obesity increases atrial fibrillation recurrence after ablation, and we also know glucagon-like peptide, one receptor agonists like semaglutide, can produce meaningful weight loss. The real question is, does that translate into less atrial tachyarrhythmia recurrence after ablation? This was a single-center propensity-matched cohort of patients with obesity undergoing first-time ablation for paroxysmal atrial fibrillation. Semaglutide was started either shortly before ablation or shortly after. And here's an important strength. Rhythm surveillance used implantable cardiac monitors, so they are not guessing based on symptoms alone. The matched groups were 181 versus 181. At a median follow-up of about 18 months, freedom from recurrence was roughly 80% with semaglutide versus about 65% without. The hazard ratio for recurrence was about 1/2, so a meaningful association. And they did not just report time to first recurrence, they also saw a lower atrial tachyarrhythmia burden over time in the semaglutide group. Weight loss was not trivial here. The semaglutide group lost on the order of 10 plus kilograms on average, with a meaningful body mass index reduction compared with very small changes in controls. Procedurally, energy sources were balanced and major adverse events like death or stroke were not seen in either group. So what is the clinical implication? The authors introduce an idea that I think is strategically important, a peri-ablation therapeutic window for metabolic conditioning. In other words, rhythm control is not purely an ablation-only solution. It can be an integrated electrophysiology metabolic intervention. But we need to be honest about causality. Propensity matching helps balance measured variables, but it does not eliminate selection effects. Access, adherence, clinician selection, and calendar time bias can all creep in. So I take this as a strong hypothesis with supportive evidence, not as a final answer. Practical takeaway: if you are ablating atrial fibrillation in patients with obesity, this paper supports being more intentional about structured metabolic therapy around the procedure, and it reinforces that continuous monitoring is the right way to measure true arrhythmia burden when you are making these claims. Next, pulse field ablation, but in the nanosecond domain and with workflow implications that could change lab throughput. Study 3 is SCENA-AF, high repetition frequency nanosecond pulse field ablation for paroxysmal atrial fibrillation. The concept is appealing. Nanosecond pulse paradigms may reduce neuromuscular stimulation, which could enable more cases under local anesthesia and conscious sedation without sacrificing lesion efficacy. This was a prospective, multi-center, single-arm study across 11 centers enrolling symptomatic, drug-refractory paroxysmal atrial fibrillation patients. They performed pulmonary vein isolation using a commercial nanosecond pulse field system. The primary efficacy endpoint was freedom from atrial fibrillation, atrial flutter, or atrial tachycardia lasting at least 30 seconds from day 91 through day 365 off class 1 or class 3 antiarrhythmic drugs. Acute pulmonary vein isolation success was 100%. At 12 months, the primary efficacy estimate was about 88%. On safety, no device or procedure-related death, stroke, or transient ischemic attack. Serious adverse events were limited to minor vascular complications that resolved without sequelae. Now the workflow piece. This is the part many labs will focus on. Over 90% of cases were performed under local anesthesia with conscious sedation. General anesthesia was used in a small minority. If you are trying to scale atrial fibrillation ablation capacity, that matters because anesthesia resources can be a bottleneck. But here is the key interpretive caution. Monitoring intensity was not continuous implantable monitoring. Intermittent electrocardiography and symptom-driven reporting can underestimate asymptomatic recurrence, so treat the efficacy number as freedom from detected recurrence, not necessarily freedom from recurrence. Clinical implication: this is a clean feasibility and performance signal. Nanosecond pulse field ablation can deliver strong 12-month outcomes in paroxysmal atrial fibrillation with a sedation profile that could materially change throughput and operational planning. The next step is comparative trials with rigorous, ideally continuous monitoring. Now let's pivot to a safety signal that demands attention, especially because it may be population enriched. Study 4 is the kind of report that can change practice faster than a randomized trial because the downside risk is so high. This is a retrospective single-center cohort of patients of Marshallese descent undergoing atrial fibrillation ablation, comparing pulse field ablation with thermal ablation. The cohort is small, 12 total patients, so we have to keep our statistical humility. But the signal is extreme. Every pulse field ablation patient in this series experienced generalized coronary spasm, and none of the thermal ablation patients did. The clinical presentations ranged from transient intraprocedural ischemia, responsive to intravenous nitroglycerin, all the way to delayed ischemia with ventricular fibrillation or bradycardic shock requiring vasopressors, nitroglycerin, intravenous or intracoronary, and even mechanical circulatory support. And notably, events occurred despite no pulse field energy delivery near the coronary arteries. So what do we do with this? This is not a paper about mechanism certainty. It is a paper about operational readiness and risk awareness. The authors emphasize delayed presentations and life-threatening potential. That has immediate implications for post-procedure monitoring strategy and same-day discharge assumptions. Let me say that plainly. If a population truly has a higher susceptibility to generalized spasm after pulse field ablation, then standard pathways may not generalize. Observation time, discharge planning, and readiness to treat spasm may need to be population aware. Limitations are obvious: small sample size, non-randomized comparison, and potential temporal confounding. But the severity of events makes this difficult to ignore. This is a rare, globally, common, locally warning signal, and electrophysiology ignores those at its peril. Next, how reliable are the implantable loop recorder alerts that increasingly drive both clinical workload and trial endpoints? Study 5 is extremely practical. Implantable loop recorder accuracy across vendors. Because implantable loop recorders are now everywhere. Stroke evaluation, syncope, palpitations, atrial fibrillation management, and their alerts can quietly create two major problems: clinic workload explosion and distorted atrial fibrillation burden endpoints in research. This was a multi-center, multi-vendor remote monitoring database, including hundreds of thousands of electrocardiogram available episodes from thousands of patients. They focused on alert events. So these are the transmissions that actually hit your inbox, and physicians adjudicated true versus false. Key result number 1. Overall, true positives versus false positives were roughly 50-50. Key result number 2. Vendor differences were large. For atrial tachycardia and atrial fibrillation alerts, positive predictive value, meaning the fraction of alerts that were truly atrial fibrillation, was about 73% for Boston Scientific, about 56% for Medtronic, about 51% for Abbott, and about 23% for Biotronic. And false positives were not evenly distributed. In Biotronic, false positives were often driven by ectopy. For tachycardia alerts, false positive rates were also high in some vendors. Now, the most important nuance: positive predictive value is not sensitivity. This study could not quantify false negatives, and that matters for high-stakes indications like post-stroke atrial fibrillation detection. But positive predictive value is what drives decision noise and workload. If your device generates 5 alerts and half are false, your clinical team pays for that in time, and your patient pays for it in anxiety and downstream testing. Clinical implications are immediate. 1. Implantable loop recorder alerts are not interchangeable across vendors. 2. Atrial fibrillation burden derived from alerts may partly reflect vendor algorithms and programming choices, not just patient substrate. So if you are using implantable loop recorder burden as an endpoint, whether clinically or in trials, build adjudication and vendor awareness into your interpretation. Now let's move into the procedure room for a different kind of signal: electrogram-based detection of septal perforation during left bundle branch area pacing. Study 6 tackles a complication we all worry about in conduction system pacing programs: septal perforation during left bundle branch area pacing. Implantation. The classic marker many of us use is a drop in current of injury amplitude, but this paper asks, can we do better by treating the intracardiac electrogram as a waveform phenotype, not just a single number? They evaluated consecutive cases with perforation and analyzed intracardiac electrograms, both filtered and unfiltered, along with current of injury measurements. They also proposed a practical definition for microperforation combining low sense current of injury, impedance drop, and capture characteristics. The baseline finding is strong and intuitive. Sense current of injury amplitude during perforation was dramatically lower than at the final position. But here's where the paper becomes operationally useful. They show that baseline electrocardiogram phenotype matters. In patients with a narrow QRS complex and no left bundle branch block, a specific rule performed well. If the Q or S wave amplitude is greater than the current of injury amplitude, that pattern had high sensitivity and high specificity for perforation. And that matters because it gives you a bedside rule you can teach, standardize, and audit, especially for teams scaling left bundle branch area pacing volume. The authors also point out a practical workflow nuance: intermittently interrupt pacing so you can analyze sensed waveforms when the pace current of injury starts trending down toward concerning values. My takeaway is simple. Perforation detection should not be a single scalar threshold. It should be a waveform-based pattern recognition skill, conditioned by baseline activation pattern. That's the level of nuanced conduction system pacing programs should build into training and recording protocols. Next, device infection risk, why the subtype matters and how PAD trial performs when you split pocket from systemic infection. Study 7 looks at device infections and the PAD score, which used 5 criteria, which were prior procedure, age, depressed renal function, immunosuppressed state, and complexity of procedure. The interpretation: low risk, 0 to 4 points, intermediate, 5 to 6 points, and high risk equal to or greater than 7 points. This trial attempts to validate the PAD risk score for infection after cardiac implantable electronic device procedures, and then goes a step further by separating pocket infection from systemic infection. This matters because device infection is not a single biological entity. Pocket infection often reflects local barrier disruption and cumulative pocket manipulation. Systemic infection behaves differently: more bloodstream dynamics, more lead-related biology, and often a different procedural trigger. This was a large prospective registry at a single institute covering all device procedures over many years with adjudicated infection outcomes. The primary outcome was hospitalization for device infection, subclassified into pocket versus systemic infection. Overall infection was under 1%, with pocket infections making up the majority. In terms of model performance, the PAD score was moderately discriminative overall, but the real insight is in the subtype divergence. They found that prior procedures were strongly associated with pocket infection, but not systemic infection. And systemic infection risk showed particularly strong association with lead revision and complex device types. So the practical message is not just higher score means higher risk. The message is prevention strategies should be phenotype aware. Pocket infection risk should push you to think about pocket biology and cumulative perturbation, while systemic infection risk should push you to think about procedural complexity, lead handling, and the specific vulnerability created by revisions. Okay, last study, a women's cardiovascular health signal that spans atrial arrhythmias, conduction disease, and device implantation over long follow-up. Study 8 evaluates polycystic ovarian syndrome and long-term risk of arrhythmias. This is important because polycystic ovarian syndrome is metabolically complex, and prior outcome data connecting it to arrhythmias has been limited. This study used a nationwide Danish cohort with over 26,000 patients with polycystic ovarian syndrome matched to controls and followed for years through early 2024. They examined a broad set of outcomes: atrial arrhythmias, conduction disease, cardiac arrest, and even device implantation. The signal they report is an elevated associated risk of incident arrhythmias over time. Importantly, it is not just one rhythm category. It spans atrial fibrillation and flutter, conduction disease requiring devices, and hard outcomes. They also report a higher incidence of cardiac implantable electronic device implantation with an adjusted hazard ratio meaningfully above 1. Now, limitations are real. Diagnosis coding is not perfect, and they do not have deep phenotype granularity like body mass index, adiposity, smoking, and other metabolic variables. Surveillance bias is possible. Patients with polycystic ovarian syndrome may interface with healthcare more, which can raise detection. But even with those caveats, the clinical implication is worth taking seriously. Polycystic ovarian syndrome may flag a broad electrophysiologic vulnerability over decades, not just a single arrhythmia endpoint. That should influence how we think about long horizon risk in women's cardiovascular health, particularly when metabolic features are present. Let me close by pulling the whole issue together. 1. Ultrashort atrial fibrillation-like episodes under 30 seconds can be powerful risk enrichment markers, often a reason to intensify monitoring, not dismiss it. 2. Semaglutide around ablation is associated with lower recurrence and lower burden under continuous monitoring, but we still need randomized confirmation. 3. Nanosecond pulse field ablation shows strong 12-month outcomes and a sedation profile that could change lab workflow, but monitoring intensity remains a key limitation. 4. Generalized coronary spasm in Marshallese patients after pulse field ablation is a high-stakes safety signal that should influence operational planning and post-procedure monitoring. 5. Implantable loop recorder alerts vary widely by vendor. What you call burden may partly be algorithm and programming, not just biology. 6. In left bundle branch area pacing, perforation detection improves when we interpret electrograms as phenotype, not just current of injury amplitude. 7. Padded is more useful when you respect infection subtype biology, not just a single pooled outcome. And 8. Polycystic ovarian syndrome appears linked to a broad arrhythmia and device implantation phenotype over long follow-up. As always, the full newsletter with references and graphics is available on the LinkedIn newsletter and also on Substack at epedge.substack.com. If you have questions, comments, or suggestions, you can reach me at epedgecast@gmail.com. Thank you again for listening and for supporting EP Edge Journal Watch. Until we meet again, take care.